Welcome everyone to another Thursday Night Live. Tonight I have with us Dr. Srinivas Kishore Sistla. He is an esteemed ENT with 28 years of experience. He's the director and head of Otolaryngology at AIG Hospitals and head of sleep apnea services in Hyderabad. An alumnus of the Manipal Academy of Higher Education, he completed his MBBS in 1995 and MS in ENT in 1999. Dr. Kishore specializes in treatments for nasal disorders, eardrum rupture, laryngoscopy, and congenital ear problems. He's widely recognized for his patient-focused approach and expertise in the field. Welcome to Airway Circle. I'm so excited you're here. We met in Brazil and you were like, I'm an Airway Circle fan. And I was just floored that an ENT liked what we had to bring. So thank you. And I know I did not do justice introducing you. So if you'd like to add anything for those over here who still do not know who you are.
Renata, at the outset, let me first thank you so much. You don't know how big a fan I am of the kind of work you're doing and the effort that you're putting in for the field and for the entire science of sleep-related breathing disorder and awake disordered breathing.
Yes.
I think I'm a bigger fan than you are, so I think the feeling is very mutual. So I think what we're going to talk today is also going to be a lot in the lines of how you think, probably, but it'll be a little different from an ENT perspective. So I think, is this going to be an interactive session or is it only me going to speak?
I'm going to ask you some questions at the end, and we do have a few members watching it live, so they may ask some questions. If they do, we'll answer them.
Sure. I think, let me then start my presentation.
Okay.
Can you see my screen?
Yes. Beautiful.
All right.
Perfect.
So good evening, everybody, or good morning, everybody, based on where you are. I'm in India, so it's 6:30-ish, so on Saturday. And thank you very much, Renata, again. Can't thank you enough for all the effort that you're putting in. Now I'm going into repetition mode. So what we're going to talk today in the next 45 minutes is what I call the nasal power and how you can unleash the power of the nose to improve just not sleep-related breathing disorder, but just breathing per se. So I come from a city called Hyderabad, which is in the center. It's in the south center of India, which is in South Asia. I think the region I'm in is sort of very exciting, and also I think we constitute to almost 40% of the world's population. And in a recently done study in our country, the prevalence of sleep apnea in my country is now a staggering 32%. And we are a lot of billions of people in my country, and that's a huge disease burden, right? So I'm in a city called Hyderabad, which is also called the pharma capital of the country. We do a lot of pharmacological APIs and things like that and formulations. We're also a little bit into IT. As you know, most Indians are in IT. And also my city is about 400 years old. So those of you who are interested, I'll be happy to host you. And that's about me and my city. But P.S., We don't have elephants and camels roaming around if that's what you're expecting to see. So, yeah, so let me just go ahead and start my presentation. So, the nose, the nose is a preferred way of air entry, and we all know that. All of us would love to breathe through our noses. So, nasal pathology has a significant impact on airflow and hence can potentially contribute to sleep-related breathing disorders. Now, having said that, the nose contributes to about 50% of airway resistance. Now, if you take a graph and you record the nasal airway resistance through a rhinomanometry, and you plot it against the AHI on the x-axis and the nasal airway resistance on the y-axis, as the nasal airway resistance keeps going up, so does the AHI. So the nose pretty well significantly contributes in a big way to airway resistance and also to AHI. That's the only metric which we measure the severity of OSA nowadays. Now, how important is nasal breathing? Nose has three very important factors or functions. One, it helps to warm the air. It actually helps in thermoregulation. It helps in humidification, and it helps in filtration of air. But what it also does is it increases the amount of nitric oxide in the air you breathe. Now, nitric oxide is something that is produced from the membranes of your sinuses, as you know, the mucosa of your sinuses, and it cannot be produced anywhere else. This is something that is very, very important and is becoming more and more important nowadays, the importance of nitric oxide. Now, this is not only important in sleep-related breathing disorder because it also improves minute ventilation, but it's also very important for the health of sinuses, and nitric oxide is also bad for bacteria that would like to grow in your sinuses. I will also talk a little bit about the importance of nitric oxide further down the road, but nitric oxide is very important. It also helps to decrease sensitivity to oversensitivity to carbon dioxide, which we call as one of the non-anatomical factors that contribute to OSA, which is loop gain. Now, what happens when one switches from nasal breathing to oral breathing? Now, during the day, when you're all sitting, now if you breathe through the nose and breathe through the mouth, what is it that you feel? Breathing through the mouth is much easier, right? So then why are we saying that nasal breathing is so important? What happens during sleep is actually once you are lying down and once you go into sleep, nasal breathing is actually 2.5 times less. Let me put it this way. Oral breathing is 2.5 times more difficult than nasal breathing when you lie down and when you go to sleep. So what happens when your nose is blocked and when you switch from nasal breathing to oral breathing? Look at this particular video of this patient. We've sort of sedated him artificially, and you can see he's opening his mouth. And so what goes wrong when you mouth breathe is that there is dryness of the upper airway. That reduces the surface tension. So once the surface tension is reduced, the mucosa tends to stick to each other. Imagine a dry day. Imagine a day where your lips are stuck to each other, and try opening it up. They get stuck to each other and it takes an effort to open your lips. The same thing happens to your pharyngeal mucosa. When your throat gets dried because of no humidification coming from your upper airway because of your nose being blocked. There is loss of surface tension and your pharyngeal mucosa tends to get stuck. So it becomes difficult for your lung to pull a closed airway because it's stuck because of reduced surface tension. Of course, because of breathing through your mouth, there is less nitric oxide, there is reduced ventilation perfusion ratio, there is increased ventilatory response to CO2, and I just told you about one of the non-anatomical factors that sort of influence sleep apnea, which is loop gain. So what is loop gain? I'm sure you will have discussed about this, but loop gain is nothing but your body's oversensitivity to the carbon dioxide. So once carbon dioxide quantity increases in your body, the thermostat in your body, which is monitoring the amount of carbon dioxide, tends to overcrank itself and tries to throw out the carbon dioxide. But carbon dioxide is also important for you. It's not a bad gas. It is also important for you to initiate your breathing response. So if you throw out all the carbon dioxide that's inside the body, that's bad for you. Now, let's talk a little bit about nitric oxide. And nitric oxide has a lot of functions. I mean, it has effects on your immunity, it has effects on your cardiovascular system, on your respiratory system, and your nervous system. And the only source for that is your paranasal sinuses. Not your nose, but your paranasal sinuses. So your paranasal sinuses, along with your nose, need to be functioning perfectly to have good nitric oxide production in your body. So if you look at one of these papers from the European Respiratory Society way back in 2002, what they did was they measured intratracheal concentration of nitric oxide during an inflow of tracheostomized patients. That means breathing in tracheostomized patients. And they found out that if you breathe through the mouth or through the trachea, the nitric oxide is negligible. Whereas if you breathe through the nose, the nitric oxide is high up, very high up. So basically, if you were to breathe through the mouth, or if you're a tracheostomized patient for whatever reason, you're not getting the beautiful effects of nitric oxide. So if you pitch mouth breathing to nasal breathing, I was speaking about this earlier. Nasal breathing is 2.5 folds. There is increased resistance when you breathe through the mouth in the night. But the same is not true when you breathe through when you are awake. It also helps to stiffen and dilate the upper airway. How does it do that? So basically, you have to be a diaphragmatic breather. When you breathe diaphragmatically, see, when you breathe, right, you're not breathing through. How are we breathing? We're not breathing through our lungs. Lungs don't have any muscles. There are axillary muscles on your thorax. Your diaphragm is your primary muscle to breathe. So if you want good diaphragmatic breathing, you need to breathe through your nose. So when you breathe through the diaphragm, when your mediastinum actually is pulled down, so does the trachea, and the pharynx. So when your trachea and pharynx is tugged down by your diaphragm because of beautiful nasal breathing, then your collapsible airway also becomes stiff, and hence breathing becomes much easier. And hence there is good breathing that's going in per breath. Here's another paper that's been published again in the International Journal of Pediatric Otolaryngology. Here they've done a three-dimensional assessment of pharyngeal airway in nasal and mouth-breathing kids. And very clearly you can see, I don't have to explain this here, nasal airway, nasal airway volume. This is oral breathing and nasal breathing. you can see it's 5,045 millimeters volume here, whereas here it's 9,000. So you don't have to, this picture is self-explanatory as to how beautifully the airway opens when you breathe through the nose. The impact of this doesn't just stop there, and it's not specific only for respiration. It's also for your quality of sleep. And here's another paper that's published in the Journal of Sleep, which is in 2018. What they've done is it's titled Nocturnal Nasal Obstruction is frequent and reduces sleep quality in patients with obstructive sleep apnea. So this is very common people who have nocturnal nasal obstruction not only causes problems in breathing, but it also causes insomnia. And if you actually measure these people's quality of life from a mental standpoint and also from a physical standpoint, you can also see that nocturnal nasal obstruction causes a lot of impairment in quality of life from a mental and also physical standpoint. And we all know the role of drug-resistant hypertension in OSA. And we know that because of the cranking up of the autonomic nervous system not functioning properly, we know that most of our patients who have not been treated properly for obstructive sleep apnea develop drug-resistant hypertension. But do you know that the nose independently causes drug-resistant hypertension? So this is again a beautiful paper, very, very recently published as early as 2022, wherein they determined the independent predictive role of nasal obstruction in resistant hypertension. So if you took away all the problems that are happening to sleep apnea in the pharynx, just as a standalone a problem, nasal obstruction can independently affect drug-resistant hypertension. So even when you treat OSA, if you don't treat the nose, the drug-resistant hypertension may not come into under control. And this has been published in the European Archives of Otolaryngology, 2023. And of course, your audience are, of course, very, very, very well known to the fact that the effect of mouth breathing versus nasal breathing on dentofacial and craniofacial development. This is published way back in one of the most reputed journals in ENT. It's called the Laryngoscope in 2010. And of course, you can look at what is happening here, the position of the tongue, the position of the mandible, changes in soft tissue, lips, tongue, etc. And if you look at all the parameters here on the left side, snoring, mouth breather 0, nose breather 0, mouth breathers 33, sleep apnea, allergic rhinitis, closed rhinoid area, mouth open at rest, everything, nasal breathing trumps mouth breathing anytime. So when you look at this and we understand that sleep apnea is getting worse because of nasal obstruction, what is the pathophysiology here? So there are four pillars through which nose can make sleep apnea worse. The first one is the very well-known fact of Starling resistor model, wherein the elevated nasal resistance upstream results in a negative pressure in the oropharyngeal airway downstream, which we also call as a suction force, collapsing the airway. Now, this is something which is very funny. Actually, as mammals and as humans, we are the only one who have sleep apnea. This is a price we pay to actually becoming bipedal. And because we need to vocalize and we need to speak, If you look at any other mammal, the larynx is right behind the nose. Because we had to stand up, we had to evolve, and we need to communicate with each other. The larynx had to come down to make way to vocalize and to develop intelligent speech. And so we actually brought in this funny muscular tube in between called the pharynx, which can actually collapse and can cause problems. So there is no Starling resistor model in other animals. Are you aware of any other mammal that snores? I don't think so. Anyway, that's food for thought. So the second pathophysiological mechanism is unstable oral breathing. So the moment you open your mouth, there is significantly increased nasal resistance results in a compensatory increase in mouth breathing. And switching to mouth breathing because of various factors that I'm going to talk to you further down the road, whether because of the tongue not having space in the oral cavity or the tongue not having enough tone, the tongue automatically starts falling backwards, and hence you would have an unstable breathing. Another very interesting factor is the nasoventilatory reflex. So decreased nasal airflow results in decreased activation of the nasal receptors with subsequent inhibitory action of muscle tone in the pharynx. And this can also cause a reduction in minute ventilation into the lung as well. This is something we all ENTs know. Sometimes when we do nasal surgery in ENT, we tend to pack the nose. And when we pack the nose, these patients get very, very uncomfortable. And there has been an experiment and a publication that they have seen that for a patient for whom a nasal surgery has been done and a nose pack has been put, patients who were not sleep apneics, their AHI actually increased. So that is the effect of nasal packing when you have patients with uh, 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 when you get a nasal surgery done and you put packs in the nose. And of course, nitric oxide, this is a wonder gas, and the more we speak about it, the better. So there are 4 pathophysiological pillars that actually help nasal breathing and make breathing better. And if you don't have these, it is bad for the patient. So there is also a lot of publications to show actually that apneic-hypopneic index decreases significantly after nasal surgery, meta-analysis after meta-analysis. This is a paper that we have done, which is a multicentric study in 735 patients, which I'm also a part of. So just to show how nose not only improves outcomes in maybe CPAP therapy or a mandibular advancing device therapy, it also helps to improve multi-level surgery outcomes in obstructive sleep apnea. So, nasal surgery is of great importance in the armamentarium of OSA due to its ability to facilitate, one, the various treatment options that are available for OSA. Let it be CPAP, let it be mandibular advancing device, or may it be multi-level surgery, whatever it is. Nasal treatments, whether it is surgery or allergy management or whatever it might be, it helps. Now, what should be also highlighted is it also maximizes patients' quality of life. So if you take a sleep apneic patient and you just do nasal surgery, and you do a sleep study after nasal surgery, or you take care of the allergic rhinitis or whatever it might be, if you do a sleep study after the treatment, the AHI would still remain the same. But the patient would come back to me or come back to anybody for that matter and said, Doc, what did you do? My sleep quality has improved significantly. To hell with the numbers. Of course, we know the AHI and its problems. And of course, this is not the platform for that, and we can continue to argue on that. But their sleep quality and their breathing quality improves amazingly. And I think we should also, and I would go officially on that platform to actually say that nasal obstruction of breathing is something that is not only for a sleep uh, time, right? It's something during the day as well. So you have dysfunctional breathing during the night. It doesn't magically get better during the day. So when you do nasal treatments, they start breathing better during the day as well. And hence, all that satisfaction of breathing comes in to thank you. So the American Academy of Otolaryngology actually put in a nasal as a position statement for nasal surgery in OSA and said that nasal surgery can improve the quality of life in patients with sleep apnea. With nasal surgery, the Epworth scale, which is one of the commonest scale to measure sleepiness, has been shown to decline from levels associated with excessive sleepiness to levels consistent with normal function. And this is not only an Epworth sleepiness scale, it's also the SF-36, which is a quality of life measure, has improved in these patients. In fact, the Koreans have taken it to the next level. There's a difference between clinical practice guideline and a positional statement. This is a clinical practice guideline by the Korean Society of Otolaryngology and Head and Neck Surgery in 2023. So nasal obstruction evaluation is a strong recommendation. Nasal obstruction, referring the patient to an otolaryngology for surgical treatment of OSA with persistent symptoms despite appropriate medical treatment is a strong recommendation. So on and so forth. There are multiple statements that they have given and about respiratory disturbance, optimum PAP levels, PAP usage time. No matter the metric, nasal treatments help to improve outcomes in whatever modality you want to treat the patient for sleep apnea. So when it comes to management, right? So I would like to bring in this concept of the container and its contents. When you talk about the nose has to be looked at as in two different ways. So here's a picture that I would like to bring in. So is the problem with the box or is the problem with the contents of that box? For us as ENT surgeons, because of all the advances in endoscopy and technology, the moment a patient comes in, we just tend to put a scope inside and just go into the nose and say, okay, this is a very crowded nose. If your patient's nose, the piriform aperture is narrow because of a deficiency there is a transverse maxillary deficiency. No matter what you do, you give the patient an empty nose, the patient's not going to improve. So first of all, the first fundamental thing that you need to make for that particular patient who's sitting in front of you is this, yes, there is a nasal problem. Is the problem because of the container or the contents of the nose? So, for example, what is the management of a patient where the contents of the problem are the problem? It can be anything. So this is a deviated nasal septum here. This is the inferior nasal valve. You can see that there is a synechia between the septum and the inferior nasal wall, makes it very difficult to breathe. Here you can see an endoscopic image where there is polypoidal changes. There's a lot of allergic rhinitis because of the whitening that you can see, the pale mucosa that's happening here. So the targets where the contents are the problem are nasal valve, synechia formation, septal deviations, turbinate hypertrophies, polyps, and allergic rhinitis. So not all deviated nasal septums are the same. Just because one has a deviated nasal septum, you don't need to correct it. So you have to grade the deviated nasal septums. So if you draw a line from the crista galli to the maxillary crest, look at how deviated it is between, so you can call it a grade 1 if it's less than 9 degrees, a 9 to 15, and more than 15. Now, why is this important? Because the more the deviation, the more the resistance. Similarly, this is the inferior turbinate. Based on how much it's causing obstruction to the cross-sectional area of the nose, so much is the resistance. So why is that important? It has been shown that patients who have lesser amounts of septal deviations and turbinate hypertrophies can be adherent to CPAP, whereas patients who have a higher grade of septal deviations and higher turbinate hypertrophies are not adherent to CPAP. So here you are actually taking off a gold standard therapy that can be offered to your patient just because the patient was not evaluated for a nasal pathology. The patient is not getting the benefit of the gold standard therapy. And this is a beautiful paper from Stanford, which basically showed just the effect of nasal surgery on PAP therapies and the percentage of patients regularly using PAP prior to nasal surgery, if it was 38.7%. After the nasal procedure, it just increased to 90.2%. That is pretty significant. Now, management of the patient in whom the container is the problem. So, this is a patient you can very clearly see here. You're doing a drug-induced sleep endoscopy for this patient. Okay. Now, if you take the scope through the nose, and you can see the palate collapsing, and these are the salpingopharyngeal folds, and you can actually see slowly, you can see the palate collapsing. Wait for it, wait for it. Right? Now you can see the palate collapsing here, anteroposteriorly, and you can see how the entire pharynx and the patient is breathing, and every breath is causing the airway to collapse. Right? That's the tongue, that's the epiglottis. What? The problem here is because of the tongue has absolutely no space. So we're working on this sign, we call it the bubble sign. If you take a CT scan and you see this, because we as ENTs do this CT scan every single day. And what we don't see, what we see is this beautiful septal deviation. Okay, agreed. But the problem is also transverse maxillary deficiency. You can see how the tongue is folding inside. So in this particular patient, what are the treatment options? No, every single patient requires surgical options? No. Because we all know that allergic rhinitis and non-allergic rhinitis play significant roles, it is also important that we have to give importance to medical management as well. But this has to be very carefully taken. So if it is mild apneic patients or UARS patients, it is good to give them a good nasal steroid challenge. But there is no point in giving 10 days or 15 days of nasal steroids and letting it go. You need to give it a good 3 months and see. So if you have a patient that can give you that kind of a bandwidth, that you can give nasal steroids for the time that it is supposed to be given, so that you're giving a fair chance for this medicine to work, then it will work. Otherwise, 10 days, it's not going to work. What about nasal dilators? There are a lot of nasal dilators out there in the market. There are breathe right strips, which are very common in my country. People use, but of course, there is very limited evidence out there that it works. Some patients swear by it, but it cannot be used in moderate to severe sleep apnea. So let's come to the surgical treatments real quickly. Now, this is a concept that one needs to understand. This is the philosophy. If the contents are the problem, if you do an amazing septoplasty or a turbinoplasty or a swell body ablation or whatever that you would do, it would work. But if the container is the problem, the container is small, you have to do something to widen the piriform aperture. If you do not do that, even if you give the patient an empty nose, the patient is not going to be satisfied. You will not be able to deliver the amount of PAP therapy that you want to deliver. The mandibular advancing device will not work properly for these patients. So whether it is surgical or a medically assisted maxillary expansion if it's an adult, or a rapid maxillary expansion if it's a child, depending on the mid-palatine suture. We can see this in a CBCT or a regular CT that we do regularly. Always remember that the suture actually sort of ossifies posterior to anterior. So it's a very important point for us to remember. Now, dealing with the contents. So a very, very important point that we need to, as ENTs or people who are in the field of treating airway, is what is called as a septal swell body. Now, we all know from CFD studies and from CBCT studies that the air would like to go through the middle meatus. It is not the inferior meatus that the air would like to go through. The air likes to go through here. So if you have a huge septal swell body here, because of either allergy or because of non-allergic rhinitis, it is important to treat this. If you don't treat this bulge, the air will not be guided into the middle meatus, and hence you would. So I would like to go on record and say, do CFDs in all patients of nasal obstruction. This is something which is very functional. It's important to treat function, not just structure. So this is a septal swell body. This is how it is. So when you palpate it, right, it's soft and boggy, right? So it is important. See how it swells? This is the septal swell body. We have to pay attention to this. And of course, the septoplasties, of course, things have become things are endoscopic nowadays. We do septal corrections. It's important that we do good procedures. Endoscopic is the mantra nowadays, but very, very important. So when we do septal corrections, do not pack the nose. It's got stuck, I think.
Take your time.
Yeah, thank you. I
And
think something wrong with
literally,
this here.
I
Let me
am
just.
blown away, making so many notes. I know everybody listening is really enjoying this. You guys are welcome to send your questions. Again, if you're an Airway Circle member, you're watching this live, and you get to interact and have all of your questions answered. And this will be playing on a future Thursday night for everyone else. Septal swell body. I wrote that down. If you can hear me, I know you're trying to. Hold on, let me do this.
Packs that have airway.
Sorry, what did you say?
So let's go ahead. So let's talk about the container. This is something that is very close to my heart uh, because we as ENTs are trained to look inside the nose. What we are not trained is to look what's down because the roof of the mouth is the floor of the nose. This is an example of a patient with a high arched palate and a normal palate. These are two consecutive patients, both coming with nasal obstruction as a primary complaint, right? So it's very important to understand dealing with the container. So this is a picture of one of the patients who, and this is the CT scan that I would like to bring you back to. So for an ENT, what we're looking at is this, that is a gross septal deviation, there is turbinate hypertrophy here, 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 agreed. But is this patient going to get better if you do just a septoplasty and a turbinoplasty? No, he's not going to get better because there is no space. So what do we do for these patients? So this is a procedure that we do, and I think for those of you who are orthodontists here or people who do peds here, this is something which is very commonly done. So this is a teenage patient for whom we're doing this procedure. It's minimally invasive. You can see the measurement. So we're doing this. We can also do a clavicular incision. So the limit is with exposing the face of the maxilla here. This is very easy to do. This is not taught to us in any of the ENT curriculum. This is something that we will have to learn from the dentists, and it is so patients are so happy. Sometimes just doing this procedure itself can actually give us results in terms of just AHI improves sometimes with this, of course, with a lot of MFT. Please remember that just doing this will not give us the results. You will still have to train the tongue to go back. It's not that it's like a tail of a dog, right? It will not automatically go back. It's trained to be curved. So similarly, the tongue will continue to fall unless you keep so so this is how this procedure is done. We've done that. So now once this is done, we put in this implant, and from day 5, day 6, we can start expanding this patient. And the patients don't complain at all. So this is one of my patients who's got this. This is an adult patient. Good expansion at the end of 3 months. Now, what is also important, and that's something that has been published, is it's just not also about the volume. It's also the narrowest part that needs to be addressed, That means the piriform aperture, which is right in front, that needs to be addressed. So they found that it's just not the volume also that matters, but it's the narrowest part of the nose that is very important that you need to expand. Not only that, for us who are ENTs who are in the future looking at this, we can also do a very simple procedure. This is called piriformplasty that's been published in the Brazilian Journal of Otolaryngology. This is called piriformplasty. So wherein you are actually widening this is the lateral aspect of the nose. You're actually drilling off the lateral aspect of the nose and making it wider for the patient to breathe. So it's not about doing a septoplasty or a calvenoplasty. You're just making the nose wider in these patients. So you can see, I'll let this run a little bit. There's so much bone in these patients. This is the inferior turbinate. So this is the anterior margin of the piriform aperture. So without doing anything in the nasal cavity, just by drilling this part, we can achieve very good space. So how do we measure our outcomes? We do four-phase rhinomanometry to actually measure a pre-op and post-op. So it's important that you do either a CBCT or a regular CT. In kids, I would prefer to do a CBCT. I do not expose these patients to adult CTs. So you can see that this whole thing, without touching the sacred nasal mucosa, because the nasal mucosa has what we call as the C fibers or the C receptors, which are the end of the trigeminal nerve. So when you play around and do the turbinoplasties, these nerve endings may get damaged, receptors may get damaged, and the sense of smell might go away. So now you can see how narrow the nose was. And now you can actually see because of this drilling. So now we cut these flaps and this whole thing becomes nice and wide. So no nasal pack. This is something which is very important. You can get packs, you get nasal splints with airway. This is allowed. You can actually breathe well through the nose with these packs. They also help in hemostasis, so that if you have to put a pack, it's important that you do this. Now, a very simple test that one can do to show whether a CPAP would work or how much resistance the nose is causing for that patient on a subjective way is to do the nasal obstruction symptom evaluation scale, so that you can actually understand and you can actually take the results from this simple scale and use it for your CPAP patients to use the best or the most comfortable nasal mask. Because if you want to give a nasal interface, the best one is the nasal pillow. But if the nose is blocked so much, you can't give them a nasal pillow. So you can do this very simple nose score. And then if the patient's score is more than 50, then giving him a CPAP with a nasal mask, especially a nasal pillow, may not be a good idea. So I would like to conclude my talk now. The secret of life is right under the nose. Of course, all of us know that, and Renata, of course, knows this very well. So, dear colleagues, I would like to stop my presentation with that, and I'm happy to take any questions. For want of time, I've actually cut it down. We can go on for hours together, but I think I will stop now and I'll be very happy to take any questions if they are.
Oh my gosh, can we please go 1 more hour? This was incredible. Thank you, thank you, thank you. I know everybody's mind is like just like mine. I have notes everywhere. Okay, Candace, she's a pediatric dentist. She was asking, what is the name of the procedure with the expander that you did? Did you release the maxilla here too, or did you
Yes.
attach something to
Yes.
the maxilla?
So we actually, it was a dental device, but he's a teenager.
Uh-huh.
So it's a device that anchors both to the jaw, that is to the maxilla and the teeth, both.
So you
So
attach us here.
yeah, and also you've seen we put a
Yeah.
MSc as well.
Mhm.
Yeah.
Wow.
So
Was that a type of dome that you guys did when
it
you were?
is a kind of dome. Yes, it is a kind of dome.
Oh my goodness, that is
Thanks to Stanley, of course.
yes, we love Stanley. Angela has a question. The surgical procedure was incredible. Is there an age that you will and will not do this?
Right. So I would not do it in the very old patients um, because uh, sleep apnea in in the geriatric age group is very different. It's a different animal altogether. So I would not do that. I would also be very careful in the postmenopausal women who may or may not have good calcium.
Mhm.
And I would do this definitely in a teenager in whom the suture is sort of fused, but you're not sure that a MARPI would work. So I would always have a dialogue with my dental colleague. So we work together. So when a patient comes to my clinic, the patient sees me and also my dental colleague at the same time.
Ah, the future of collaboration, everybody. Every dentist needs their ENT and their myofunctional therapist. This is
The
wonderful.
vice versa. Every ENT needs their dentist.
Yes, and vice
Because
versa.
I've learned it the hard way, especially my tonsil adenoid patients,
Yeah.
right? Some of them they do well, but some of them they just don't do well. The mom is back with scary videos of this child not sleeping well, right? So I was like, where am I going wrong? And that is so I started going to all the dental meetings, and that is when I actually opened my eyes, said that this is we are not talking to each other.
Yes, and it's
And
right here.
that's the biggest problem. We are like neighbors and we are not talking to each other.
Oh my gosh, that is so true. That was going to be my next question. Tonsils and adenoids. Can you touch a little bit on that? Why do you think? I know there's so many, trains of thoughts out there about what makes tonsils and adenoids enlarged.
So there are many theories out there. So things like, see, it's basically a result of inflammation, is what I think it is. If you have a cascade of inflammation happening in the body, either because of a disturbed breathing or because of the kind of food you're eating, something that needs to trigger that inflammatory cascade. And then if you add an other factor that's making the inflammation worse, because all of us know that sleep related breathing disorder causes inflammation, right? So what is tonsil and adenoid responding to? It is responding to inflammation, right? So it's
Mhm.
your policeman, right? So it's trying to make you get better. So it's cranking up itself. It's becoming bigger and bigger to take down that inflammation. Now, while this is going on, your kid has a ton of sugar or you have bad dietary habits. So
Mhm.
then there is a second cascade of inflammation falling on this. And sleep related breathing disorder causes reflux as well. And that can cause your adenoids and tonsils to swell. Now, where will this kid go? right? So obviously, we will have to unclutter this complex. So every child is different. You cannot have like, okay, you've seen a grade 4 Brodsky tonsil, take it
Mhm.
out. No, get
Okay.
to the bottom of what has caused the adenotonsillar hypertrophy in this child in the first place. Is it allergy? Is it reflux? Is it sleep related breathing disorder? See, when you talk about this, it's a kind of a chicken and egg story. What came first? And if there is allergy, you have to treat allergy. Allergy treatment is very, very important. You have to do your skin prick test or your RAS test or whatever test that you want to do. Try to identify, because allergic rhinitis, unlike septal deviations, can make things worse. Because for septal deviations, your body is compensated because it's always there, right? So your body has adjusted to that septum.
Wow.
Whereas allergic rhinitis is coming and going, it's coming and going. So your body does not know how to compensate and it tends to collapse more. So it's important that we treat your allergic rhinitis.
How early is it too early to fix a deviated septum? What do you usually do?
So again, if the septal deviation is one of the causes of obstruction, and we know that the cartilaginous part of the septum is ready by age 2, it is not going to grow beyond that. It's important that we know the growth centers of the nose.
Okay.
And if you do not touch that, there is tons of literature out there that says that if you have a gross septal deviation and you do not pay attention to that, they will continue to grow. They will continue to have adenoid facies. Just removing an adenoid and not correcting this septum will not do justice for that child. It's not possible for the patient or the child to come back to convert them from an oral breather to a nasal breather if you have a gross septal deviation. It's a waste of surgery if you
Wow.
just do an adenoidectomy.
And do you see many people who get septal deviations corrected and then it deviates again?
Yes.
Why does that
If
happen?
you because your treatment in the form of septal, see, it's like cooking a dish. See, you want to cook a dish, there are different ingredients to it. You don't put in that particular ingredient, your dish doesn't come out well at the end. So it all goes back to planning for the child or the adult for that matter. If you do not reverse mouth breathing and bring back nasal breathing, and you do not bring the tongue back to where it has to sit high up in the mouth, you will continue to mouth breathe. And again, it's a waste of operation.
That makes some.
It's an entire waste of operation.
So pretty much with septal deviation, you can correct it on a young child if it's needed.
Yes.
Okay. You're
And don't stop there. After correcting the septum, you need to do your myofunctional therapy. Try whatever it takes to come back to nasal breathing. So just doing a nasal surgery or an adenoid surgery and washing your hands off, you have to own up that child and do justice.
okay. And before taking out tonsils and adenoids, no matter how large they are, usually you try different things to see if we can get them to shrink.
Yeah, yeah.
And have you seen them shrink where they no longer needed surgery?
Very few.
Mm-hmm.
I'm an ENT surgeon at heart,
I know.
but
I'm
so
right
to be
there with
very
you because when
honest,
I see them, I have two patients this week that were grade 4, And the
Right.
dentists are sending them to me going, let's try to change diet. And I'm like, well, if they have OSA, I'm like, let's just go ahead and get them out.
Yeah,
So I,
exactly. So it depends on the size. So if you do an RME, the adenoids do reduce. I think there are two ways why they reduce, I think. One is, relatively speaking, the adenoids go down because you're increasing the real estate in
yeah.
that area. So, relatively speaking, to the maxilla, the adenoid has come down. But I also think that the child is breathing better now. So, inflammation is coming down. And I think also because of that, your police is reducing the force of the of how big it is.
Mhm.
So, but if you have a grade 4 adenoid, about a 90% block, and you have a child that's choking almost every day, you don't want to wait for the entire cascade to go down. You don't have time.
Thank
So
you.
you cannot have a one size fit all kind of, as we call it in sleep apnea, you cannot have a one size fit all side of a sort
Coach.
of a yeah, approach.
You
Yes.
also mentioned, very important to note, that the suture it calcifies posterior to anterior. How is that
Yes.
relevant to dental expansion?
So yes, because the kind of the device that you want to put, right? You want to put a fan device, or you want to put a MSC device, or what do you want to put? It matters.
Mhm.
So that is why it's important to always look for that suture in your CBCT.
I
I
love it.
very clearly see.
I have heard a few other dentists say, or a few other doctors say, that you have to expand the posterior in order to really notice nasal changes.
Yes, you have to expand the entire box. And also, I'm sure you've heard about this, the newer paper from Philadelphia from Raj Dedia. They call it two pen, wherein they compared dome versus ease versus two pen. And I can share that
Please.
data with you, and which can actually, it's called two pen like in Penn University,
Okay.
two PENN, two as in the numer. Yes, that's correct. I will share that with you on WhatsApp. Actually, I have a presentation where we've compared the results of dome to ease to two pen.
Oh my goodness, that's incredible. I can't wait to see that. And last question. You talked about the septal swell body. What is that exactly for us non-ENTs?
So the nose has a lot of pseudo erectile tissue that
Mhm.
swells and shrinks with the environment that you're in, and the response to the allergens. So it is one. So most of this tissue is on the lateral walls of the nose, but sometimes it can be on the septum itself, and that's called the septal swell body. So if you don't pay attention to that, it's still going to be swollen. And the patient would still say, I'm stuffy, I'm still not better.
Ah, so it's not actually the turbinates, it's actually the septum that will swell up because of inflammation.
Yes,
And what
yes.
can patients do to reduce? It's just reducing inflammation mainly.
Rinse the nose first is the
Okay.
most important thing. I mean, nasal rinse has such good, I mean, it has a 1A recommendation in all guidelines and all position statements everywhere. Any other than avoidance, of course, if there is any other recommendation that's a strong recommendation, it's nasal rinse. The power of the nasal rinse is second to none. So even if you want to give a steroid spray, um, even before you give the steroid spray, if it's a child, I think you should just rinse the nose and give the steroid spray so that the intranasal corticosteroid spray works better.
Ooh. Oh my gosh, I have so many more questions, and I know I said last question. So do you recommend nasal rinses to everybody? Is there a certain age or reason why I
Oh,
would say don't?
it's normal unless there is somebody who has a neurological disorder and who's going to aspirate
Okay,
and he's not mentally sound. I would give them nasal rinse. And
perfect.
in
No.
fact, the more the volume, the better it is.
Oh, because that was going to be my
Yes.
question. We usually in myofunctional therapy, we talk about two ways of cleaning the nose. One, just nasal sprays. And then the other one I like to call a nasal clearing, where you actually run saline through your nose from one side to the other side, or you can even swallow it if you know how to do it properly. Is there any negative indications or contraindications, I should say, or negative consequences to doing the rinse and a lot of this nasal clearing with saline?
If you have a neonate, then you need to be careful of the salinity of that
Okay.
wash because they can, if you're talking about a neonate or an infant,
Mm-hmm.
but after 3 months, you can nicely use it. There's no problem with that.
Perfect.
In fact, there are a lot of studies that show that more is better. So they've taken all kinds of sprays and they've done a control study, and they found out that it's actually the volume of the spray that matters. So we call it Jalniti in India. It's called the neti pot, if you know. Jal is water in Hindi. That's our language. So Jalniti, that's what we do, and the you have people doing that all the time.
So frequency, it is okay for them to do it daily.
Yes, you
I
should.
love it. I love it. I love it. I love it. Dr. Kishore, thank you so much. This has been seriously one of my favorite Thursday Night Lives. I really appreciate everything that you've given to us today. And people are asking, can you please have him return? What an amazing presenter, great explanation, excellent teacher. Thank you.
Thank you so much, Anita. The pleasure's mine.
Oh,
Pleasure's mine. I love your shows. Thank you so much.
well, now you're a part of it.
Yes,
Yes, thank you
thank
so
you.
much.
So,
Everybody have a
yes,
wonderful night. We will see you next Thursday. Bye-bye.
you. Bye.